Sir, we are in live, sir.
Dear Facebook Pure Urology viewers, good evening one and all. Every alternate day or other day we are discussing the surgical technique based video presentations by national and international faculty for last 1 year. Today it's a special day. Any surgery which is first time done is always well appreciated, even though lot of hurdles will be there. One such surgery is extending the indications of endoscopic urology, that is simultaneous bilateral endoscopic surgery. As you all know, supine PCNL has definitive advantages. Even myself, I saw doing lot of RIRS for the large stones where I felt need of some cases PCNL in the supine position. That's why I converted into supine PCNL. Surprisingly, it did not end there. Supine PCNL combined with RIRS is endoscopic combined intrarenal surgery, ECIRS. To my surprise, when I have seen today's speaker, Professor Guido Giusti, mentioning the word simultaneous bilateral endoscopic surgery with a beautiful picture published showing the OT OR setup, unbelievable, and I did 1 or 2 cases. It is, everybody said, where is the need? Why should you be in a hurry? But imagine if the patient has problems with general anesthesia, with a small stone one side, with a big stone another side, what is wrong if the urine culture is sterile? That is the topic of the today. Already it is published by Guido Giusti sir. I am doing it. Many people are appreciating it. It is time we have to listen that and go ahead. Let us see how Guido Giusti sir has gone into the field of simultaneous bilateral endoscopic surgery. What made him to think that urethra is accommodable for ureteric catheter and access sheath? What made him to two surgeons coming together and doing a teamwork? With this introduction, I will take brief information from Guido Giusti sir and then hand over the program to sir. Guido Giusti sir, good evening.
So, good evening everybody. Thank you very much for your invitation, which I'm really proud of. It is a great pleasure for me today to share my experience in a simultaneous bilateral endoscopic surgery. That is, I would say, the last frontier in endourology. Actually, this is a great satisfaction for me to share my experience in the field, because I think that at this moment in time, in which we have a limited access to the OR because of this horrible pandemic, of course, it is mandatory to try to do our best to optimize the time in our OR in order to take care of as many patients as we can in our limited access to the OR. So thank you very much, and I hope, yes.
I wanted to ask you, when did you develop interest in urology in your career? Who is your first mentor?
Sorry, I didn't hear you very well because there was some problem with the connection.
When did you develop interest in urology, and who is your mentor in endourology?
Well, I graduated in urology back in 1996, and after this graduation, I had a clinical fellowship with Dr. Clayman in St. Louis. You know that Dr. Clayman is one of the pioneers of endourology, and most importantly, he was the first to perform laparoscopic nephrectomy back in 1991. Then I spent the whole 1996 in St. Louis, and all my career, I would say, started from this city under this incredible mentorship by Dr. Clayman. That, of course, when I came back to Italy, I started to do everything on my own, but always keep in mind all the teaching of my mentor.
Yes, sir. When did you shift from PCNL to RIRS? Do both surgeries, or you are favorite for one surgery?
I think that the modern endourologist to succeed should be familiar with all the techniques. I don't believe that you can treat all the stone with PCNL, but I don't believe too that you don't treat all the stone with the flexible ureteroscopy. So you should be familiar with all the techniques. Only in this way, every time you will choose the best surgery for this stone, for that patient. So you have to adapt your skill to the patient and not vice versa, because otherwise, if you push too much PCNL or flexible ureteroscopy, sooner or later you will be a little bit in trouble. This is my personal opinion, of course.
Sir, when did you start your flexible ureteroscopy? And what was the first?
I started more or less in 2005, 2006, more or less. So actually 16 years ago.
Which scope you used in the beginning part of your career?
Sorry, which?
Flexible scope you used.
I started with the Flex 6.2, the first generation, the fiber optic one.
Yeah, yes.
Okay.
Now, last couple of questions. Do you think that the ECIRS and access to bilateral simultaneous endoscopic surgery, will there be only one position, that is whatever the position you suggest for all the management of the stone, including laparoscopy if at all you fail in upper ureteric stone? Do you think that this will change the prone to supine era?
Well, I think that in 10 years, prone PCNL is likely to disappear from our OR. But now we have to wait a little bit, because the surgeons that are not very young, they started with prone. So it's not easy to convince, let's say, older people to change practice at the end of the career. But actually, most of the young urologists are learning supine. So you will see that in 10 years, actually, we can say that 80% of PCNL are done in prone, 20 in supine. You will see that in 10 years, it will be the opposite. 20 prone and 80% supine. And believe me, I think that I can be very reliable, because don't forget that before shifting from prone to supine, I had already performed 1,000 prone PCNL. So I do know what I'm talking about. Yes. I'm not like our American friends that they are criticizing supine without having done one single case. I performed more than 1,000 prone PCNL. And so that okay.
Sir, my last question before I hand over the program and before I introduce you officially. Which size of the stone, depending, of course, there are various factors. I should not ask like this. If you have everything in your front, in the pelvis, easy anatomy, which size, which volume size you think that, oh, I will go for flexible ureteroscopy? No, I will go for supine PCNL, because you have two both at a time available. Just matter of going from one seat to other seat. So generally in your...
Listen, my friend, usually I am very flexible, not only with my scope, but also with the indications, you know. So it is very difficult to be definitive in the office. All my patients with stones bigger than 1 centimeter, they always sign an informed consent in which they know that I will start ureteroscopically, but if I will have the feeling not to do a good job, they will allow me to shift to supine PCNL. So I would say that my limit, for sure, over 2 centimeter is PCNL. But sometimes in a very difficult lower calyx, if I'm not able to do a good job ureteroscopically, the patient is already in position and I will shift very easily to supine PCNL. So remember that the final decision in my practice is not in the office, is on the operating table in the OR.
Great. That is the main advantage of converting from flexible ureteroscopy supine PCNL, because you need not change the position too much Today, the talk main essence is that in your mind on table, if you decide you want to shift, it is matter of only 1 minute. Take the instruments, go to the lines,
Yes.
then start. This is the major advantage. Let us introduce the pioneer, the dawn of the supine as well as flexible scopy, Professor Guido Giusti. He is the head of the Stone Center and European Training Center of Endourology at San Raffaele Choro Hospital in Milan, Italy. He is from basically Italy. He graduated in medicine from School of Medicine of University of Verona, again Italy. In 1991, he entered residency of urology at School of Medicine, University of Verona, Italy. His entire life is from Italy. In 1996, he attended the Division of Urological Surgery of Washington University School of Medicine in St. Louis, Missouri, USA, directed by W.J. Catalona for a full-year research fellowship in endourology and laparoscopy with Dr. R.V. Clayman, who is supposedly the one of the father of the modern endourology, particularly laparoscopy as well as endourology. He graduated in urology from School of Urology at University of Verona. From January 1997 to June 1999, he served as assistant professor at Department of Urology at the University of Verona. In June 1999, he moved to Department of Urology of Humanitas Research Hospital in Milan. Since September 2008 to May 2015, he was the head of the Department of Stone Center of this institution. Since June 1st, 2015, he joined Hospital San Raffaele Choro staff to establish a new stone center for this hospital. Since 2012, he established the European Training Center for Endourology under the patronage of SIU, Italian Society of Urology, and ULIS, EAU branch for urolithiasis. And he chaired more than 144 international courses in 6 years with doctors coming from 19 different countries. He is the author of more than 270 abstracts, 270 hues in national and international congress, 88 papers on indexed national and international journals, and 15 videos of surgery. He performed more than 40 live surgeries in the field of endourology in the most important national and international congress. In 2015, he chaired the 14th Italian Congress of Endourology with more than 400 attendees. He held the flexible uteroscopy course during the annual meeting of EAU in Barcelona, which I have attended, Wien, Paris, Milan, and Stockholm, and Madrid and Munich. Thank you very much, sir, for giving this opportunity, a wonderful academic track. With this introduction, I hand over the program to Professor Guido Giusti, sir. Please take your time. This is for us, it is a one-time valuable 1 hour or half an hour, which will be there as YouTube link forever. Forever means as long as the YouTube will be there. Thank you, sir.
Okay. Thank you very much for your generous introduction, especially for putting this picture in which I was at least 15 years younger. Thank you very much, much appreciated. And now we can start with my lecture.
If I have any doubts, I will interrupt in between. Please don't mind, sir.
Yes, sorry, what? Just a moment, please. Okay. Let's go back. Share screen.
Yeah.
Okay.
Perfect.
Ready to go.
Yes, sir.
Again, thank you very much for your kind introduction. And now let's focus on the topic of today, which is, I would say, the flagship of my Stone Center, which is simultaneous bilateral endoscopic surgery, which, as I told you before, I consider the last frontier in endourology. So, wait a moment. How can I remove this?
No,
Okay, no.
We are able to see it completely.
Yes, but I would say hide self-view. Hide. Okay, I just wanted a little bit.
If you want to,
sorry.
You have to minimize. If you are missing something on the screen, you have to minimize. There is
yes, because okay, perfect. Okay, so let's go back to my lecture. Urolithiasis is a common health disorder in the Western world, and we all know that it is steadily increasing. And actually, we have a lifetime risk of stone formation as high as 10–12% in male and a little bit less in female. And the prevalence of stone disease is keeping on increasing in the last 2 decades. Similarly, also the incidence of bilateral renal stone is not negligible, because actually it can be found in up to 15% of our patients. And of course, it implies a huge amount of patients also with this bilateral problem. Historically, there have been always major concern to treat all kidneys in the same session, because the hypothetical, I would say, risk of acute renal failure due to the manipulation of both renal units in the same moment. And of course, it was also supposed to be bearing a higher risk of development of complications. That's why most of the surgeons decided in the past to perform a staged surgery. But you know what? After I started with this bilateral treatment, I was so happy because I was treating both kidneys all together. And once I was talking with one of my best friends, who is a liver surgeon, and he told me, Guido, why you are celebrating because you operate both kidneys? Of course, it's a little bit more risky, but if I would do the same, operating all the liver, I wouldn't operate because the liver is only one. So basically, if you respect all the indication, as you can see, we have already demonstrated that respecting the safety rules in bilateral surgery, actually, we cannot tell you that we don't experience a high risk of complication, while we reduce the number of times that we take our patients in the OR. And you see all the papers that are coming from my center and also from other centers which we are collaborating with. First of all, there is a problem of terminology. This is most important, very important, because actually also in the medical literature, there is some confusion about that. So staged bilateral surgery means that we take care of both kidneys in two different surgeries. So one side first, then in a second surgery, a delayed second treatment for the other kidney. Then we have a bilateral single session procedure. We operate on one side first, and when the first surgery on the first side is finished, if this was an uneventful procedure, we take care of the same kidney in a second moment in the same surgery. Then there is the topic of today, SBES, simultaneous bilateral surgery. That means that we operate on both sides and in the same moment with two surgeons operating in tandem. So this is bilateral simultaneous surgery, because most of the time on the medical literature, there is the terms simultaneous is used to refer to bilateral single section. So simultaneous means two surgeons operating on both kidneys in tandem, okay? So honestly, I was not the first to consider simultaneous bilateral surgery. This is the first medical report about simultaneous endoscopic surgery, but this is not referred to PCNL and a combination of PCNL and flexible ureteroscopy, but as you can see from this picture, is referred to a bilateral simultaneous flexible ureteroscopy with two surgeons operating on two different kidneys with two flexible ureteroscopes through the ureter. Honestly, with two surgeons operating elbow to elbow with the other surgeon. Honestly, I consider this an appealing surgery, but a little bit, I would say, too problematic, and also a little bit too carrying a higher risk of complication, because of course we know that the septic complication is more related to flexible ureteroscopy. Operating with flexible ureteroscopy, with two surgery, with, let's say, potential risk of high renal pressure in the kidney is a little bit risky. But honestly, the result reported by this center were very good, but basically this was a case report. And as far as I know, I have not seen any bigger series about this topic in the following years. Then there is this, I would say, provocative surgery from my friend Mario Sofer from Israel that some month ago published on Twitter. This very tricky picture in which he was doing a simultaneous bilateral flexible ureteroscopy, handling both by himself, both ureteroscope on two different kidneys. And honestly, I think that in this picture, Mario has exaggerated a little bit, because I think that if you are not a one-man band, I think that it is very, very difficult to have a full control of both flexible ureteroscopes in both kidneys. Honestly, you know what is funny? That the first simultaneous bilateral endoscopic surgery I performed back in 2016. Look at this gentleman in the background. Maybe you recognize this gentleman. Is the king of flexible ureteroscopy. Is Professor Traxer from Paris. In this year, we were planning many courses together. And even though he is against bilateral surgery, he never performs bilateral flexible ureteroscopy in his center. But during this course in my hospital, watching this CT scan, he told me, Guido, this is a good indication for simultaneous bilateral surgery. That's why we performed this first case that we published on Urology back in 2016. And it was the first case in which we performed PCNL on one side, while Professor Traxer, as you can see from this picture, was performing flexible ureteroscopy on the other side. After this first case, we perform many cases. We are reaching, actually, if I'm not wrong, more than 70 cases of SBES. But in 3 years ago, in 2018, we published the first series of simultaneous bilateral surgery on European urology, as you can see. And we were lucky enough that this paper was also chosen to be put on the cover of that issue of December 2018. And most importantly, don't forget that this paper is in the surgery in motion section. So there is the possibility, the chance to download the video for free from the surgery in motion section through the website. So this is a very important step, positioning of the patient. We always use this, our position, which is a little evolution of the Galdacca position, where the patient is, as you can see, in supine position with a little elevation of the flank that should be operated with PCNL. You see my coworker, Dr. Porietti, operating on the table, and you see that basically this was the position that we start with. The only problem is that sometimes we have some conflict of the nephroscope, the rigid nephroscope, against the metallic support of the stirrup. And especially in supine, sometimes when you want to reach the upper calyx, you have this problem of conflict, so you cannot move the rigid nephroscope enough. So that we change actually our position since 2 years. And you see that this stirrup is only on the contralateral side where we are supposed to perform flexible ureteroscopy, while on the PCNL side, we keep up of the table so that we don't have any conflict any longer with the metallic support or the steel up. But the position is more or less the same, with a little elevation, with a little elevation of the flank, that unless there are retrorenal column is more than enough to reach the posterior lower calyx that usually is the calyx that we prefer for the first access.
Can I interfere, sir?
So, yes.
One question. You kept the straight. If you keep the ipsilateral limb of the supine PCNL straight, will it obstruct the RIRS surgeon? If you keep in slight lithotomy of the left leg, does it make comfortable to RIRS surgeon in the opposite side? If it is bilateral simultaneous endoscopic surgery?
Well, I would say that with this position, of course, there is a little bit more room for the ureteroscopic surgeon. But believe me, that also with this position, there is room enough also for the second surgeon to perform flexible ureteroscopy. The only problem of this position is if you have to perform semi-rigid ureteroscopy, because you have a conflict with the semi-rigid scope on the leg of the patient. But actually, if I have to tell you the truth, we are not using any longer semi-rigid ureteroscopes. So it's very rare for us to use a semi-rigid. So if you start directly with flexible ureteroscopy, as I will show you later on, usually this is not a problem.
I personally feel to put the guide wire, you need semi-rigid ureteroscope. That part, when you go to the extreme left in this case, you feel the limb is slightly touching, and especially if the suspensor ligament is very tight, sometimes the left ureter looks high and you have to bend and you have to turn a little bit to the opposite side to insert the guide wire. Otherwise, most often with the straight limb, supine PCNL becomes more easy. It's okay.
I agree with you, but if you become very familiar with flexible ureteroscopy, usually this is not a problem, usually. Of course, there are some cases in which you can have this problem. You are definitely true.
Thank you.
So setup of the OR is of utmost importance, because we have to keep a lot of instrumentation inside the OR. And of course, we have to be systematic and to be, I would say, always doing the same steps, because otherwise also the nurse team will get crazy. So remember, this is also because we have a very small OR, and of course we have to do always the same thing in order to be very fast in set up all the organization of the OR. So you see the bed, as I told you, one scrub nurse, one ureteroscopic surgeon, myself, my assistant, anesthetist, CR, and also laser, and also ultrasound machine. So remember to be systematic and to always do the same step. Otherwise, you will lose a lot of time just in setup. Look, this is the way that we start with. You see my coworker, Dr. Proietti, she started with flexible ureteroscope, flexible cystoscope, and she placed ureteral guide wire in both systems, you see. So we have occlusion balloon on the PCNL side and ureteroscope access sheet on the flexible ureteroscope side. You see, this is the first step. Incannulation of both ureters, occlusion balloon for PCNL, and ureteral access sheet in view of flexible ureters. And you see that also in the male, there is room enough to accommodate both devices in the urethra. So at this moment, you see that my colleague is able to start with flexible ureteroscopy and with LITHOTRIPSY. And from now on, both surgeons will be operating in tandem. Look, on this video, you see Dr. Proietti perform LITHOTRIPSY, and on the full screen, there is myself performing mind puncture in supine. And this time, as you have seen, I was lucky enough that we can go back. Remember, this is an important trick. The less you rotate the patient, the easier will be your puncture. And in this time, you see, this was an easy kidney, of course, but I was able, like most of the time, to puncture the kidney at the very first effort. Look, you see, I was moving clearly the kidney, so I was in the correct position. Look, first effort, urine coming out from the needle. So at this moment, I introduce my guide wire. I use only hydrophilic guide wire. This is a zip wire from Boston Scientific. And when I have enough guide wire in the upper collecting system, I feel satisfied with this. Look, again, it's important, even though you are an expert surgeon, I'm always used to keep a safety guide wire to keep the way. Remember that in endourology and in bilateral surgery in particular, the limit between a masterpiece and a disaster sometimes is very small. So I always want to be very prudent, and my choice is always to keep a safety guide wire attached to the drape of the patient. And you see that in this moment, I use my occlusion balloon. This is the Nephromax dilation balloon from Boston Scientific, which can be inflated up to 18 atmospheres. I use mostly 24 French access, which is big enough for me, especially if you are supplied with the modern lithotripsy, so they are very fast. And from now on, look, Dr. Proietti is doing LITHOTRIPSY ureteroscopically, and I'm performing lithotripsy with my rigid nephroscope with my lithoclass master on the contralateral kidney.
Can I ask a question? Can I interrupt?
Yes, with pleasure.
In the supine PCL, if you have a thick guide wire, after the
if you have a stick,
in supine PCL, once you enter into the system and see the stone,
yes,
the guide wire appears to be a little hurdle for the stones to pass out. I usually remove the guide wire in supine PCL once I enter into the system, once I am comfortable. Is it necessary? Because the gravity down of the fragments will be less if the guide wire is there. Do you think the guide wire should be kept for entire surgery, or you can remove it?
You know, my thinking is like your safety belt in your car, you know. I am lucky enough that I have never had to use my safety belt in my car, but this is not a good reason not to use it. So I use every time my safety belt in my car just in case, and I do the same in the OR just in case. Don't forget, in my center, I'm not the only surgeon. There are also my young colleagues, my fellows. So I always want to operate in full safety. If you are an expert surgeon, like I guess you are, you can also avoid to use safety guide wire, but my suggestion is always to use it. Honestly, this was a big kidney and I had a guide wire in the upper calyx, but my suggestion is always to incannulate the ureter and to have the guide wire down and coiled in the bladder, just to avoid this inadvertent slipping out of the guide wire, which is one of the problems of supine position. But if you feel safe enough, go ahead and don't use it. But the first time that you will lose the way in PCNL, you will remember my suggestion, my friend, okay? The guide wire.
I appreciate that safety measure. Do you use phenomenal amount of irrigation from the ureteric catheter in supine PCNL when compared to prone PCNL? You have done 1000 prone PCNL. You are now supine PCNL. Do you think that you require more irrigation in supine PCNL with ureteric catheter, with balloon or not?
I don't think so. For sure, we we need a little bit more irrigation because, of course, the inclination of the upper sheet is like this. So we have a continuous outflow. So sometimes this is a problem because in a prompt PCNL, you are used to work with the kidney full because the orientation is like this. So first you fill the kidney, then you will have extravasation. Instead, being supine, being the ampulla sheet like this, the kidney tends to be empty. So you need more irrigation. Sometimes if you have, let's say, too much outflow, a trick can be a little bit to close the gap between the scope and the ampulla sheet with the gauze in order to keep a little bit more irrigation. But don't forget that this is, at the end of the day, a factor in favor of supine because having this bigger outflow, you have lower intrarenal pressure. That means less risk of infection. And together with a friend of mine from Brazil, we have just published this paper. You can take a read of it on Journal of Urology, just last month, in which has been demonstrated that in supine PCNL, intrarenal pressure is lower and supposed to be a beneficial for our patient. So going back to the video, you see in this moment, look, myself performing lithotripsy with my lithoclass master and Dr. Porietti keeping on performing surgery on the contralateral kidney. So you see fragmentation is very fast from my side. And as soon as we have fragments, you see my nurse name is Mimmo, always collaborative, always supportive, and also a fellow. Maybe a criticism from your point is, Guido, we cannot afford to have 3 surgeons in the OR. Maybe this can be a problem. That's why I always love to have a fellow in my center. Because remember, this complicated surgery is much better in 3 rather than in 2. And when we have a big fragment, like in this case, look, sorry. No, I did a mistake, okay. Look, in this case, I was using the NPERC by Cook, which is a single-use basket to remove big fragments. Now, look, there was some remnants in the upper calyx, and I couldn't reach them with my semi-rigid scope. That's why I introduced a flexible digital ureteroscope. This is from Castors. Look at the quality of video of the image. And I introduced a basket, you see, through my flexible ureteroscope. And I was able to reach the upper calyx. And by using this single-use basket, this is, again, a basket from Boston Scientific, which is a single-use basket. It is like the N-Gauge from Cook. And I was able to reach the upper calyx in order to render this gentleman stone-free. So, because in this case, don't forget that also in supine position, you can also manipulate the patient also with your flexible nephroscope that at the end is a cystoscope, okay? And again, look how we have to be synchronized. You see, myself, Dr. Proietti, and what is good is that in every moment, both surgeons should have both videos under control. So Dr. Proietti is able to watch his screen, which is the screen dedicated to LithoView. And this is another good point. In simultaneous bilateral surgery, we always use single-use scope because, of course, the dedicated monitor for LithoView is much smaller, and we keep only one endoscopic tower for myself, okay? But you see, myself have full access to my video, but also to the video of Dr. Proietti, and vice versa. Silvia can watch her video, but she can also watch my video that is not visible on this because it is on this side of the OR. So both videos easily reachable from both surgeons. Let's move on. Exit strategy. This is an important point. Most of the time, the PCNL surgeon terminates before the ureteroscopic surgeon. This is one of the advantages of PCNL. You are much faster than flexible ureteroscopy. Of course, in this video, we have put both exits simultaneously, but in reality, I finish a little bit first. But as I do most of the time, I check my tract on the way out, and Dr. Proietti is checking the ureter on the ureteroscopic side. This is very important because if you have a problem, a tearing of the ureter or any other problem, of course, we can decide to keep bilateral stent for a little bit longer. Usually we leave the stent for 10 days, but of course, if you have a ureteral tear or you have some problem, we can decide to keep the stents bilaterally for a longer time. This is an important point. We all know that bilateral stenting is very disturbing for our patient. But honestly, I don't care. It's better to have some problem with the stent rather than to develop an acute renal failure. There are some papers in which it is reported an acute renal failure after bilateral surgery, but this was just because bilateral stenting was not utilized. I always place bilateral stents whenever I operate patients bilaterally. This is an important point.
Can I ask a question?
Yes, please.
Sir, if you are doing the supine PCNL, if you are injecting contrast, especially in the early part of your career, by putting a small nephrostomy and inject contrast so that you can track if any chance of injury in the beginning.
Sorry, I didn't hear you. You introduce contrast through the tube. Why?
Show that there is no contrast leak in the pericatheter colonic injury. Hello?
Look, my friend.
Yeah,
I checked the tract on the way out. Sometimes it has happened that I was through the colon, you realize immediately. But remember, with your eyes, you see better than on X-ray video. And if you do like this, if you go through the colon, and I'm lucky enough that I went through the colon only a few times, you realize immediately. So it's better to check with your eyes rather than with contrast. Seeing is believing.
Yeah. But that it also accepts that if you come out, you are not putting nephrostomy. If you are coming out with, you are not putting nephrostomy.
Most of the time, I don't place any longer nephrostomy after PCNL unless there is an important story of infection. The tube after PCNL is completely useless from my point of view. It's only a matter of habit, because in the past, not to place a nephrostomy at the end of PCNL was considered a kind of crime. But now it is not that any longer this way.
Thank you, sir.
But look at this again. You see, safety guide wire is always in place. So I am always in time to place a nephrostomy if I have doubt. If I don't, I remove it. Okay? Now let's go through some data regarding this paper that we published.
Okay, sir.
So, look, this is our series, and look, This is an important point. If you want to perform bilateral surgery, of course, indication is the most important point. You don't have to schedule for bilateral surgeries for SBES difficult cases. You have to schedule for bilateral surgeries, easy to medium difficulty cases, basically cases which have a high chance to be rendered stone-free in one single surgery. Otherwise, it's better to take care of one side first and then the second side in a second surgery, in a delayed second surgery. Look, not difficult stone on PCNL surgery side, only more or less 3 centimeters in diameter, and not difficult case on flexible ureteroscopy side, a little bit more in average than 1 centimeter. This is a very important trick. Don't schedule difficult cases for bilateral surgery, okay? What about complications? Look, OR time is very convenient, and this is possible only because of supine position. Remember that this is operating time from beginning of intubation till the extubation of the patient. It is not like in the series of prone PCNL in which the OR time is calculated from puncture, skipping the preparation, the positioning of the patient. This is all included. It is 1 hour, 20 minutes for bilateral surgery. Hospital stay is 2.7 days. You know, in Italy, we are very prudent about discharging of the patient, and the mentality of the Italian patient is maybe a little bit different from the Indian or from the American people. In Italy, we are lucky enough that patients have access for free in the hospital, and so they want to be discharged when they are in good shape. They are almost ready to play tennis. That's why the discharging is a little bit long. This is just because they want to be in full shape. Sorry, my telephone is ringing. And primary stone-free rate is quite acceptable, 74% stone-free on bilateral on both kidneys. This is an important point. And look at that, complication rate is more or less the same of our standard PCNL, okay? So far, we have been lucky enough not to have transfused patient in our series. Look also about the renal function. So far, we did not experience acute renal failure, and the discrepancy in creatinine and serum creatinine after surgery is, I would say, negligible, and no acute renal were experienced so far just because we place bilateral stents every time. So again, in conclusion, it is important to stress this concept. Ideal candidates to SBES are patients bearing bilateral medium to small size stone who have a high chance to become stone-free after one single surgery. No history of infection, of course, and patients should be very motivated, and they have to sign the informed consent related to the surgery. Remember that in this moment, there is no one single guidelines reporting by SBES. So if you have a legal problem with SBES, you can have some problem because there is no guidelines reporting SBES. So be prudent with the indication and don't exaggerate, because otherwise you can have problem in the future. So which are the pros of SBES? We have, of course, a reduction of operative and anesthesia time because surgeons are operating in tandem. And this is an advantage also for the patient, because there are some papers that have shown already how there is a connection between duration of the surgery and of course, post-operative cardiopulmonary complication. And of course, this is definitely an advantage for the hospital because, of course, there is the reduction of overall operative time, and of course, you treat patient bilaterally in the time on one single surgery, and of course, supine PCNL facilitates it a lot, and of course, this is also a pro for the country because, of course, there is a reduced cumulative hospital stay because the patient is hospitalized only one time and the absence from the work is definitely reduced because the time to return to normal work is definitely an advantage. So this is an advantage also, let's say, from a social point of view. There are some cons. On the other hand, we need a very important and complete equipment. And of course, this is an advantage for urological companies. We use a lot of equipment, and of course, ideal situation is with 3 doctors in the OR and 1 nurse. For some people, there is an increased complication rate, but I don't agree on this point, as I told you before, and I have demonstrated this in my series. But this is another important point. The remuneration is not in favor of bilateral surgery in Italy, as well in the United States. I don't know about India, but if you operate in connection with public health system, look, I do the best for my patient and for Italy from a social point of view, but the second surgery is reimbursed only 50%. So I do my best and I lose a little bit of money. So sometimes the manager of my hospital are not very happy with SBES because I lose 50% of the reimbursement of the second surgery. But honestly, I don't care because in my opinion, remember that our judges are not the manager, but our patient. If I am loved by my patient, this is all I look for, not the satisfaction of the manager. Of course, also this is important, but I prefer to be appreciated by my patients. So in conclusion, if you respect indication, it is not true that bilateral surgery is carrying a high risk of complication, and it is definitely an advantage for patient, for hospital, and for healthcare system, and also for the surgeons. And this is particularly important in this moment in time in which, due to this horrible COVID-19 pandemic, we have a limited access to the ORs. But of course, it is not because of this that our patients are quitting to develop stones. We have always more patients with stones, so we have to optimize our utilization of our OR. Of course, we don't have to do a world record of endourology, but we have always to operate in full safety, respecting all the indications. This is very important. If you are in doubt, stage the surgery, don't take risk, because bilateral surgery can become very, very difficult and also carrying some risk of important complications. Remember, teamwork is essential to succeed in this very demanding surgery. And I like always to repeat this sentence: if you want to walk fast, walk alone. If you want to walk far, walk together. Thank you very much for your attention. And of course, I am available for any question that you might have. Thank you very much.
Thank you, sir. Naresh and Swami, can you close the screen, please? We'll have a quick fire questions. 10 questions, fire. Okay, Guido, sir, Professor. Number 1 question. Is it okay, sir?
Yeah. Yes,
If
okay.
it is positive, do you make essential to make the urine culture sterile, or you give antibiotic and proceed? Number one question.
Well, I honestly, I wouldn't perform a simultaneous bilateral surgery starting from a positive urine culture. Try to imagine to have a problem. Yes.
Yeah.
Sorry, you stopped me.
Hello.
What you asked me?
I understand. If the urine culture is positive, you don't do SBES.
Or let's say it's risky. Try to have a septic shock after simultaneous bilateral surgery. Then you are in the court of law defending your position because you have been sued by your patient. You perform such a demanding surgery starting from positive culture. You will go to jail in Italy. So I wouldn't go for simultaneous bilateral surgery.
Yeah. Number two question. What is the absolute indication for SBS? Before you answer, I think if any patient does not want anesthesia again and again because of aspirin and clopidogrel, who is poor socioeconomically, I do SBS. Your opinion?
Well, honestly, aspirin for me is not a complication any longer for PCNL. So, and also for SBES, I would. Clopidogrel is a little bit more risky, honestly. So usually we bridge clopidogrel with heparin. But honestly, this is, in my opinion, this is not a real contraindication for simultaneous bilateral surgery, because don't forget that the bleeding risk is only on the PCNL side at the end, so like a normal PCNL. So this is definitely not a contraindication for simultaneous bilateral endoscopic surgery.
My third question, majority of the Chinese are performing bilateral RIRS with 2 sheets in the urethra, especially in female, post-stented, doing one at the top, one at the bottom, with 2 screens, simple laser lithotripsy with RIRS. Do you justify?
I don't. Honestly, I don't. To place 2 ureteral access sheet in the female patient is not a problem. To place 2 ureteral access sheet in the male can be risky, especially I would say in Chinese people. You know that the Chinese people, maybe also Indian people, you have a smaller ureter, maybe I suppose also smaller urethra. So, you know, don't forget that if you damage a urethra, this will be a problem for the rest of the patient life. So I don't like simultaneous bilateral surgery. If you mean for bilateral simultaneous surgery, bilateral ureteroscopy, I prefer to perform one side first, then the second side in the same surgery. This for sure. But to have 2 surgeons operating elbow to elbow, honestly, I don't like.
My fourth question. If simultaneous bilateral endoscopic surgery is planned, I feel puncture, pass a guide wire, do dilatation, see the stone, and then tell the RIR surgeons to start. Is it correct or not? First supine PCNL surgeon priority. Respect the kidney, puncture, dilate, see the stone. Okay, you start. Because supine PCNL surgeon will finish faster.
Honestly, I don't do this because usually Dr. Proietti starts by placing the guide wire. So usually she is ready before myself. But honestly, your thinking can make sense because the more risky side is the PCNL side. So once you are on the safe situation on PCNL, maybe your suggestion is good. Once PCNL access is okay, go ahead also with flexible ureteroscopy. Otherwise, you will have maybe a problem while the other surgeon is already operating. Maybe this is a good point.
Yes, sir. My fifth question is, do you recommend bilateral stenting a few weeks before to under local anesthesia without extra financial burden to the patient? Because I am the hospital owner, I am urologist. I see both. I am the hospital owner, I am the hospital urologist with a team. If you stent with no financial burden, I am very comfortable in doing bilateral surgery. Ureters are dilated, distendable, free flow will be there. I'm not worried about sepsis. I'm happy. Do you agree that, particularly for RIRS surgeon, stenting, if you are placing SBES, is more appropriate for the audience who argue against this?
Of course, flexible ureteroscopy is definitely facilitated by pre-stenting. But honestly, I don't use pre-stenting because I do mainly flexible ureteroscopy. If I have also to take in the OR or in outpatient OR patient just to place the stent, for me, honestly, it is impossible. And don't forget that stents are also disturbing for our patients. So actually, we have also limited access to the OR. And honestly, I know that at the end, you know what would happen? That I place the stent and I'll tell you the patient, in 2 weeks, I'll operate on you, then emergency, this, and these 2 weeks will become 2 months. And for the patient, it will be a problem. And my friend, if I ask you, if you were the patient, would you like to have 2 weeks of stenting before the surgery?
I always like. I have done more than 5,000 RIRS surgeries. I love to have, if at all I have to undergo bilateral endoscopic surgery, 2 weeks of stenting with 3.5 French stent. I love to have under local anesthesia. Sorry, sir. I love to have.
Okay. I mean, you know, these are personal habits. So I don't want. Of course, flexible ureteroscopy is definitely facilitated by pre-stenting, for sure. But actually, you know, we have a very small scope. So for me, actually, it's very uncommon not to be able to go into the kidney. It happens 1 time a year, I would say. Now, especially with the brand new 7.5 from Pusen, it's very difficult. So I skip this pre-stenting. But if you feel comfortable by doing this, why not?
Sir, last question I wanted to ask. Many people are arguing after your surgery, I have done bilateral simultaneous endoscopic surgery. They think that is brutal, cruel. Do you think the sepsis rate is more leading to mortality, leading to costly antibiotics if you do bilateral? I believe no, no, no. What do you think, Professor?
Of course, my answer is, again, no, because otherwise I wouldn't perform simultaneous bilateral surgery. Of course, as I told you in the beginning, if a patient is infected, I wouldn't go for bilateral surgery. But so far, there is no scientific evidence that there is a high risk of a septic complication. Remember that septic complications basically is related to flexible ureteroscopy, not to PCNL.
Yes, sir. That's why I was telling about stenting. I agree that, sir. That's why I was telling about stenting in Indian scenario, where the outflow of the outflow of the normal saline, if it is very good, I am very comfortable.
Okay.
Sir, with your permission, we have already 1 hour. With lot of respect, with lot of enthusiasm taken from your paper, I want to show only 1 minute video. Will you permit, where I have done simultaneous bilateral endoscopic surgery? If you permit, I will show that and we'll conclude the session.
Okay, perfect. I gave you 5 minutes, then I have to operate. Eh?
Thank you very much, sir. I have done many, but I wanted to show the bilateral simultaneous endoscopic surgery. Am I visible and audible, Swami?
Yes,
Yes, sir.
I can see.
48 years old male patient, old CBA, cannot wean off from antiplatelets, history of AK, 2 stones, 1 big, 1 small. You can see the stones here, bilateral stented. This is the position of the patient with respect to Giusti, sir, and Valdivia, sir. Guido Valdivia is watching the program. He already said hi to Giusti, sir. This is the position I copied from Giusti, sir. And I am inserting with ureteric catheter and an access sheath with visual operator method with 4x6.5 ureteroscope and the access sheath of 9x11.5 hook. Over that, I will insert that. First, I will do PCNL, large stone. In the PCNL, whatever Dr. Giusti sir has shown, kidney moves like this. You will be slightly lateral, no problem, but we will be through the calyx. I pass the guide wire, go into the kidney. Now I will say that, please, RIRS surgeon, you start. I don't have fear once I have an access. RIRS surgeon will start, so I don't harm the kidneys. I have gone inside with Alken dilatation system. Again, thank God to the Alken, the stability will be more, the kidney movement will be less. This is a suction devised from Kaushik Shah from India. Then I go inside and both surgeons are action in now. One is into different calyces, other person is only for 1 stone, and then you start doing the left side, RIRS, right side, PCNL, and we compete, we try to finish faster, and we ensure that water outflow is there. At the end, we finish the surgery. Thank you very much. This is a picture at the end of the CT, stone-free rate 100%. Even though it is reconstructed, in axial cuts also, there are no stones. Thank you for giving permission. Giusti sir, immensely happy. This is one of the best program I have ever seen, and you are well known in Italy as well as Europe for your innovative thoughts. I have been in touch with Oliver Traxler, sir. I have sent the YouTube link also. He might be watching, and nearly more than 300 audience have watched the program, and this YouTube link will be there forever, and so that many will watch and learn the new techniques which you have adopted with your vision, and with your vision. There is a controversy, lot of seniors are arguing that sepsis. I feel if the urine culture is sterile, that point will not arise if you stick on to the basic principles. I hope you agree, Giusti sir. Your conclusion remarks, then we will close the talk. Thank you very much.
So thank you very much. I just want to tell you to congratulate with you. In your video, you just replicated all my steps, I would say. And most importantly, the indication was perfect. Small to medium sized stone. And you did a great job. And I'm very happy to realize that SBES is taking over all over the world, which is, of course, is of some satisfaction for me. I know that the average skill of Indian endourologists is very high. So for all of you, for sure, is not going to be a problem to embrace this procedure completely. And now I have to go back to my OR to perform a PCNL. I thank you very much for your invitation. And I hope that you have seen something interesting for your practice. Thank you very much.
Thank you, sir. Thanks a lot.
Bye-bye.
Dr. Who is the consultant urologist at Preeti Hospital, who also has to moderate. Actually, I am traveling. I stayed outside in a hotel and doing this program. I am really happy that the connection is correct and we will have this program will be viewed by the many juniors in India and across the world. More than 6,500 urologists.
Okay.
They will learn, they will practice, and they will do justice to their patients. Thank you very much, Guido sir, Dr. Siddhalinga Swami. Thank you very much. We will conclude the session with this.
Thank you, sir. Thanks a lot.
Okay.